Dr. Chad Gordon's here to bring it home. Yeah, this guy's won more awards than Sylvester Stallone. He's an expert in reconstruction and implants. He even holds several of his own patents. Yeah, he's a pioneer and expert in his industry. Yeah, Dr. Chad Gordon rocks. It's plain to see.
Why this new field of neuroplastic surgery? I want you to stare really hard at this individual, 27-year-old, suffering from traumatic brain injury, losing half of his skull due to the injury and swelling of his brain, and then reconstructed by way of neuroplastic surgery with a custom implant. This could be your father, your brother, or your son, who is afflicted by neurosurgery and a life-changing operation. And so the goal of neuroplastic surgery is to restore him to his whole appearance so that he could live the rest of his life in peace without the deformity of having brain surgery. And I will introduce you to him later in this talk. I also want you to introduce yourselves to this woman and stare closely at her head to look for a deformity, to be able to recognize that she has an electronic device in her head, the shape of a deck of cards, that sends shock waves to her brain 30 times a day so that she can live with medicine-resistant epilepsy. This is the true essence of neuroplastic surgery. Now, in the 1950s, we learned that breast cancer management should include plastic surgery from the beginning to improve outcomes. But yet, 70 years later, we're afflicted by the fact that neurosurgery still manages these brain tumors and skull tumors and tumors around your face in a unidimensional way. And only after complications arise is the plastic surgeon invited to help with care. And that needs to change through neuroplastic surgery. We've also identified counterintuitively that the child is taken care of in a multidisciplinary fashion when it comes to skull deformities. And 8 to 10 individuals around the world will work through these clinics to help these young children with congenital skull deformities. But after the age of 18, when you're afflicted with skull problems from neurosurgery or trauma to the head, that you're only treated with a single neurosurgeon who's an expert on the brain. And only when there's problems is the plastic surgeon involved from the beginning. And that will change with neuroplastic surgery. For example, on the left is a congenital deformity such as synostosis, and on the right is a traumatic skull and brain injury, which has a different healthiness of scalp, skull, and many different comorbidities that children don't have, such as smoking, chemotherapy, and radiation therapy. And so it really needs a new medicine specialty such as neuroplastic surgery to bridge this gap of knowledge. And we will change that. We first described this in the Journal of Craniofacial Surgery back in the year 2015. And since then, we founded this new specialty on 3 pillars, such as research, education, and patient care, to really improve outcomes and to drive innovation unlike that has been done in the last 100 years since neurosurgery started. Now, if you look in the literature, regardless of plastic surgery articles or neurosurgery articles, the complication rate for skull reconstruction is almost 35 to 40%, which is mind-boggling. And in fact, in this latest article from Stanford, after 8-year study, 1 out of 3 skull reconstructions fail. And this is not acceptable. And that was the obvious need for neuroplastic surgery. And in fact, we look at the domain of neuroplastic surgery as really the hood of a car. And the analogy is that you go in for brain surgery almost having your engine worked on. But neuroplastic surgery needs to open that hood and close that hood so that there's no deformity of the hood to make it known that you had work on your engine. And if you look at our data over our first 500 patients, we've dramatically reduced the complication rate by several-fold, down to 15% from the high 30% range. And from a business perspective, the value proposition is that patients love it, neurosurgeons love having these colleagues, insurance companies enjoy knowing that there's less complications to pay for, and the health system enjoys knowing that there's a team approach. This is truly improving outcomes at the same cost and driving healthcare value. The use of the skull space is one of the true tenets of neuroplastic surgery, and this was described as a low-profile intracranial device. And since then, many billionaires have also jumped onto this storyline, which is modulating the brain with embedded technologies, such as Brian Johnson, Mark Zuckerberg, and Elon Musk through the latest endeavor known Neuralink. Now, Neuralink learned about neuroplastic surgery and what we've driven innovation through, and the obstacles we're challenged about using devices above the skull. And here is a video of him explaining his challenges.
So we want to radically improve this by multiple orders of magnitude, improve it by a factor of 100, then 1,000, then 10,000. So going into the Neuralink architecture, what we've done over the past year is dramatically simplify the device. So we about a year ago, we had a device which had multiple parts, including a piece that had to sort of sit behind your ear, and it was complex, and you wouldn't still look totally normal. You'd have a thing behind your ear. So we've simplified this to simply something that is about the size of a large coin, and it goes in your skull, replaces a piece of skull, and the wires then connect within a few centimeters or about an inch away from the device. And this is sort of what it looks like.
What's exciting for neuroplastic surgery is this is the exact innovation we envisioned in 2015, as you see drawn here in our patent application. And so how do we push this momentum forward to reach the tipping point of neuroplastic surgery? What's important to realize is this is not the first time in modern day medicine that we've approached innovation by removing one's own tissues, such as what was described in 1968 by an innovative orthopedic surgeon who wanted to enhance the function of someone's leg with osteoarthritis. The idea was to replace a diseased area in order to improve function. And that is very similar to the approach we're describing here for the first time through neuroplastic surgery. The approach would be to remove the skull space and to replace it as a way to innovate and drive neuroinnovation as a way to modulate our brains as we age and encounter disease. And so in the same fashion, orthopedic surgeons that are fellowship trained oversee these knee replacements. And in the same fashion, we will have an American Board of Neuroplastic Surgery to oversee skull replacement. And where are we going here next? Well, to begin, I need to talk about the original findings of neuroplastic surgery, which were in the top image. The original skull implant was designed to replace your bone. And when you move from the picture on the left to the picture on the right, you would still end up with a deformity simply because the implant was not replacing the missing muscle and fat. And so the first breakthrough patent innovation of neuroplastic surgery was to change the dogma of skull reconstruction to include a bulked out area for muscle and fat repositioning and augmentation. And this was described in neurosurgery with a patent being issued. And so neuroplastic surgery now envisions the future of not just offering our patients standard cranial implants, such as you know today, but the future represents functional cranial implants with embedded technologies as a way to modulate or observe the brain. And why is neuroplastic surgery so important? Because we've suffered from a bottleneck of neuroinnovation since neurosurgery started in the early 1900s. Many neuroengineers have spent lots of time, energy, and money to really drive innovation through above the skull space. And this is challenged by the fact the scalp is thin and you can't put bulky devices above the skull. Other neuroengineers have been challenged by placing these devices under the skull, which doesn't work because of impingement on the brain. And so it's really neuroplastic surgery that founded this new real estate and the intercranial space to drive neuroinnovation. And again, this was described as a low-profile intercranial device approach, and it was really a disruptive way to innovate through the skull space, as you see here. The first low-hanging fruit was to modulate the way we use batteries and wires for epilepsy. As you see here, instead of causing bumps and deformities and trauma to the scalp and leads under the galea or the scalp layers, we wanted to reinvent the wheel here. And so we created the world's first skull implant to encapsulate neuromodulation device so that we could achieve the reconstruction here with a deck of cards, a large device, and to prevent deformity, as you see there. The Wall Street Journal asked to come visit us and said this was extremely fascinating, our approach to modern day neuroplastic surgery. And since then, we've modified to a two-piece design to really minimize the invasiveness of having your battery changes every 5 to 7 years. And then someday you will come into the clinic and get a little battery on the side of your head, almost changed like a micro SD card. This was published in the top neurosurgery journal as an experience, first in human. We've also tackled hydrocephalus by, instead of using high-profile shunt valves and leaving patients with deformities and threatened scalps, we've created the world's first skull implants to modulate the position and to set it at a lower position to improve the appearance and safety of hydrocephalus. And instead of on the left causing scalp wounds, we can get the results on the right. And it's quite obvious what type of approach you would want. This was published in the main neurosurgery journal, and in fact granted the cover, which showed neurosurgeons around the world the new avenues of innovation in neuroplastic surgery.
And we are good on video.
Excellent. Okay. So we have your incision here, Mr. H, and it looks very nice, looks great. It goes from here to here. And because I use a straight line, I'd rather not make an incision with a receding hairline. I'd rather not make an incision that goes like this to get this in. So I make a little longer incision that's retracted. Now this is healed up. This is a 3-week incision, and it looks quite good. And as you can see, there's no lumps or bumps from a shunt. And the concern was, is it still going to, program well? Are we still going to be able to do the programming? And as long as you know where your shunt was placed, you have no problems programming it, okay? And this shows beautifully here exactly where the shunt is. And even the devices where you use the discs that use the magnetic, you can find them in the same way. As long as you know approximately where the shunt is, you place this over it, and then you find the shunt right there. Okay? So it's quite, effective in terms of that. No problems with finding the shunt when you, and it can be a problem because it's so invisible, you can't find where the shunt is. So
this was a video showing how that the overall function of the shunt would not be adjusted just because of a lower profile and a safer approach. For innovation, you need to do multidisciplinary and multi-center trial investigation, which is what we did here with 25 patients, as you see, coming in with threatened scalps and leaving with proper contours. And so we also thought to ourselves, what else could we shine through this implant? We were visibly going through this implant well. We were sending radio signals through this implant well. And so we thought to ourselves, what about ultrasound? So we went to the laboratory and we investigated the concept and innovation of using an ultrasound through a scalp and through a skull implant for monitoring the brain. And this had never been done before, and we used clear implants, and we evaluated all the implants on the market. And we found out, and we started doing this clinically, that this was effective, and we could see small fluid collections just like a CAT scan on an ultrasound. And we could see ventricle size just like on a CAT scan, but on an ultrasound. And when we started doing this, neurosurgeons around the world started to catch on to this concept, such as someone in Baylor in Texas started monitoring the small blood vessels during Moyamoya disease surgery with bypass grafting to shine an ultrasound through the scalp and the implant to see if the patency of the graft was present, rather than getting an expensive and labor-intensive angiogram or MRA, MRV. I was asked to comment on this editorial, and I mentioned to the audience that, as Helen Keller said, often we look so long at the closed door that we do not see the one that has been opened for us. And I truly believe this is the fact with neurosurgery. Just like we, for 30 years, have been making skull implants, now that we can see through them and work with technologies, it's similar to the approach of Enzo Ferrari's when he transitioned from the 350 Spider to the 360 Spider in 1999. I also think that we serendipitously identified a new way to monitor our brain tumor patients, as you see here. This is a patient 6 weeks out from a meningioma resection, and the brain tumor cavity is concerning to both the patient and the doctor. And so now, just like you look at a baby through a cold jelly on the abdominal wall, what you see here is cold jelly on the head at a 6-week post-op visit. And for the first time ever, a neurosurgeon is now able to look inside your head and look at your tumor cavity to let you know that there's nothing there, rather than getting an expensive MRI or a radiation-heavy CAT scan. I also believe that an interesting case presented itself to us that gave us a great amount of opportunity, which was this young lady who got shot in the head with brain swelling, and her mother was fraught with apprehension that the pressure put on the swollen scalp and brain would cause damage to her young daughter. And so we came up with the concept that we would put the world's first biosensor inside a skull implant and create a smart device like never before. And what you see here is a passively activated wireless wand that allows us to look at the intracranial pressure inside a patient 5 days after skull reconstruction, almost like a smartphone. And so the impact here is that this innovation is similar to switching from a flip phone that's strictly to call to a smartphone, which changed your life. And I think as the world of neuroinnovation drives further with smart cranial implants, we will have a similar impact. And we published this as the world's first smart cranial implant with pressure monitoring in operative neurosurgery. What's most exciting to me and has been the most challenging to date is for 5 years, we successfully developed the world's first MRI-compatible pump-assisted medicine delivery cranial implant, which will allow neurosurgeons to bypass the blood-brain barrier and to use a reservoir under the scalp that can be filled up with a needle, and to allow us to provide convection-enhanced delivery of medicines, especially to people with brain tumors and chronic neurodegenerative disease. And we're excited that Johns Hopkins has approved us to start putting these into large translational animal studies in March of this year. This is the team making the magic happen. And again, I want to remind you, Elon Musk switched his entire design in 2019 to something in line with neuroplastic surgery in 2020. He changed from a bulky device behind your ear to something using the skull space. And so this is extremely exciting for our field of neuroplastic surgery. And so again, he went from getting a link to something very similar to us, which was getting a lid and a similar image and diagram shown here. They also have been many videos from Elon Musk that he's doing translational investigation in swine. And I'm excited to report that we're doing the same thing here at Johns Hopkins. And I want to make you aware of this important concept. This is the patient I introduced you to in the beginning of the lecture with a hemicraniectomy defect. And this patient could not only need a skull reconstruction with a custom implant, but can also need a neuromodulation device for epilepsy, or a high-profile programmable shunt for hydrocephalus, or a medicine wafer to help him with his brain tumor, or a deep brain stimulation device with a battery on his chest. But the future shows that we can achieve this type of reconstruction, and I challenge you again to look for deformity. And we can do it unlike ever before with personalized medicine through the skull space as the ultimate implantable neurotechnology. To summarize the last 10 years, you've seen an innovation in the way we address soft tissue management, ultrasound through your head, placement of high shunt valves, biosensors and smart cranial devices, neuromodulation inside an implant, and now medicine delivery through the skull space. I want to remind the audience to stay creative, follow your passion, and rethink all possibilities through innovation, as the AO Foundation stands for. I want you to also remember, don't just talk about it, be about it, which shows the world's first case of using a cranial implant, replacing 35% of the skull, and a concept to embed the neuromodulation or hydrocephalus shunt valve inside that skull implant. I want to remind you how the bag phone transitioned in 2 years to losing the bag and how that changed our lives. And 23 years later, we got the iPhone 10. I want to show you that in 2 years, we transitioned from solid implants to integrated implants, and really the exciting concept that we have 23 years of working together and how far we can take this. I want to again thank the past AO president, Dr. Paul Manson. I truly believe that we see further thanks to the shoulders of our giants. And I want to take this time to thank Mr. Steve Schwartz and the entire AO Foundation for this opportunity. Mr. Ivy Hall, who's been an extreme enthusiastic supporter of neuroplastic surgery and a wonderful leader for the sector for which we operate in. I want to thank Mr. Alex Hirschlinger for his forever support in this initiative to drive innovation. He's been a wonderful partner along the journey. And on behalf of everyone here at Hopkins and the AO Foundation, we thank our patients for allowing us to innovate in neuroplastic surgery. Thank you very much.
Well, thank you so much, Dr. Gordon. Congratulations on these publications and the advancements in this specialty. I know you had some polls, and my understanding is people answered those. Please have your questions come in while we go through those polls. Can we show those, please? And then we'll have Dr. Gordon comment on those. Dr. Gordon, can you see the poll? And
I can see
can
the
you tell
chat.
us what you think?
Where do I see the poll?
It's up there in the screen.
Oh, okay.
It is a little small.
The patient's head has a large custom of replacing a hemicraniectomy full defect. There you go. So 6 out of 10 people. Now it's a little tricky because if you say the patient's left, that's on the right side, and it's really the patient's right, which is the left side when you look at it from the front view. So the takeaway here is 60% said the patient's left, which would have been the right side, so 60% were wrong.
Okay, do we want to bring up the second one? Yep. There we go. Would you like to comment?
Okay, this says that 54, this says which half of the patient's head has a large implant with a computer inside. 54% said the left side. It was actually on the right. So 54% of the audience were incorrect. And I think this is just evidence to support that neuroplastic surgery is on the right path.
Great. Jim, go ahead.
Hey, Chad. One question that I think is an interesting one to delve into a little bit is when you innovate and you're doing something that's really new, yet we all would like where it's possible and gives good care for patients to be able to get care near their homes. How do you balance that you guys are the innovators? Do these people need to be sent from all over the United States to Johns Hopkins? And then at what point can you all export it to other centers? What's the balance there to make sure we're getting the top quality outcomes in this unusual and innovative thing with making it more regionally available potentially?
Thank you. That's an excellent question. So let me start off by saying I think it really depends on a partnership. And I would say that the AO Foundation is the perfect partner for this scenario. We come at this with a multi-tier approach. The first thing we do is we do an annual symposium ourselves where we match up with industry and we find the experts in the field, such as Dupree Synthes and so forth. And we use the collaboration between academia and the commercial parties to go around the world really to do either virtual webinars on this topic, or we try to do an in-person meeting every year. And we've been successful for the last 5 years pre-COVID. Now that's an in-person meeting. And as you alluded to, you only have a limit of maybe 100 or 200 attendees. The next step in really pushing this forward is to create the next generation of surgeons who have these principles embedded within their training so that they can go around the world and build their own programs so that people don't have to come to Baltimore. I am extremely proud to say that we have a fellowship in neuroplastic surgery, and we've trained several surgeons that are boarded in their specialty and then spend 1 or 2 years with us. Several of those trainees have gone on. One of them is now the chief of neuroplastic surgery at the United States Navy. Another one is now the head of neuroplastic surgery program at the Ohio State University. We have another graduate who started a program in Tel Aviv, Israel, and the list goes on. So I think we're coming at it from different angles. Number one, we're happy to do virtual webinars as presented today, but as you know, unless you're one-on-one in person, it really limits the boundaries. Number two, we'll do a fellowship every year to train 1 or 2 individuals who want to dedicate their career to this. And then lastly, we'll do in-person meetings as well as the virtual webinar. And as Osmosis is doing, you can go global with virtual education. So that may be the best tenet moving forward.
Thank you.
Yeah, great. So there was a question on talking about these sophisticated technologies and how do we account for the eventual failure of them? Does it require revision surgery? Have you seen a lot of revisions, and sort of what's the lifespan of these technologies?
Yeah, that's a great question. So the first way to think about this is this was the same question that came up in 1968 when an orthopedic surgeon was so bold to say, your knee has osteoarthritis and we can't just put in a rod and screw over it. We have to open up a box and take out a plastic implant. And back then, the infection risk of a plastic implant in the 70s and 80s was quite high. But with repeat practice and going to experts that do this on a daily basis, the risk of infection and revision surgery gets dramatically lower. For instance, if you look at our first 500 or so cranial implants, our infection rate is around 3 or 4%. Now, if you take a surgeon who does 1 or 2 skull implants a year, that infection rate goes up for obvious reasons. So I think as we partner and we bring on a relationship and we work with such as the AO Foundation and we spread the knowledge, we can drastically improve outcomes on a global basis rather than a small area such as in Baltimore. I think not only is it about the surgeon getting expertise, I think it's time-tested knowledge. And so when knee replacement started with plastic implants or ceramic implants or titanium implants in the 70s and 80s, you didn't just need experience, but you needed time, because the time allows you to figure out which patients do better over the long term, which have a higher risk for revision. I'm very privileged to be able to dedicate my entire career to this. So I do skull implants every week. This is all I do. So I've gotten to the point now where I can self-select which patients are at the highest risk for failure or revision, and I think that drives the outcomes in the right direction. And so I think that's the answer to your question.
Thank you.
Chad, do you see any potential for implanting sensors or nano devices into total joints?
Yeah, actually, I've been working on this for several years. I have some patent applications on that. It was after doing the skull implant for the first time and putting a pressure monitor in there for that young lady who was shot in the head, it became obvious to me that for the last 30 years, we've been selling skull implants and knee replacement joints and hip replacement joints that have no openings inside to provide biosensing. It doesn't make any sense to me. Look at your phone and how the phone changed our whole lives. I can't imagine waking up in the morning and not being able to check the weather or finding the directions to the new restaurant. And I think 30 years from now, we are going to laugh to think that we put in knee implants or hip replacement or skull implants with no biosensors in them. I actually think in 30 to 40 years, we'll be laughing at this lecture saying this was so obvious.
Yeah, sort of expanding on that, someone asked about peripheral nerve injuries and using implantable devices in areas that you don't necessarily have to replace something, but what do you think of that technology?
So I think technology is a tool. And I think first and foremost, you need expert surgical care and medical care to help that patient. And I don't think technology will ever trump a primary suture repair of a nerve that gets transected in the acute setting, right? You still need expert surgical care. But theoretically, if God forbid you have a car accident and your nerve gets severed in your arm and the surgeon does an excellent job repairing it, it is true that technology could be embedded at that time to perhaps monitor the blood flow to the area of that nerve anastomosis. And so I think technology could enhance the insight on the acute postoperative phase as well as the chronic postoperative phase.
Great, thank you. Jim?
Yeah, I wonder, and I don't know if you experienced any of this or not, but Gandhi and others have noted with innovation and new ideas, there are kind of three stages. The first one is they laugh at you. The second one is they attack you or fight you. And then the third one is that they join you. Did you go through those phases? Were you laughed at one point? Were you attacked at one point? Any pointers or tips on how I know I talked to Joe Schatzker, and he was definitely attacked when he brought AO back to North America way back when. Any thoughts on how to handle it if you were, or are there some moves you guys made where you didn't hit that?
Yeah, that's another outstanding question. I think to try to pioneer a concept that basically goes 180 degrees from the way I was trained was extremely difficult. And yes, there was a lot of, let's say, ridiculing and so forth. And let me try to summarize it this way. Craniofacial surgery, really was embedded by Paul Tessier in France for pediatric craniofacial surgery, which was using bones and manipulating the face and cranium to change one's appearance. But the tenets of craniofacial surgery was born on like replacing like. And so as a child, if you have a skull deformity, you should use bone to replace it. I will tell you, over the last 10 years, I've given the same talk that I just gave now, and many times there was obvious laughing that this surgeon is talking about taking out someone's own healthy skull and replacing it with a man-made implant to improve the function of the brain. And I would say it over and over for the last, 8 to 10 years. And so, yes, there was a lot of ridiculing in the beginning. And now what I think people are seeing when billionaires like Elon Musk start doing the same thing is when people start to copy, I think it gives you a lot of credibility that I didn't have, or we didn't have way back then. So I think now we're in that probably middle phase that Gandhi talks about. And I think I'm going to give you a little foreshadow that in 20, 30 years, I think we'll be in the third phase. And I bet all of us on this call and this webinar will experience that 1 in 5 of us over 65 will have a neurological disease. And that's a staggering statistic. And 1 in 5 of us on this webinar today, when we have that disease, will realize that we can't get a new brain. And the only way our doctor and surgeon can help us is to modulate our brain. And the way you modulate is with technologies. It could be batteries, wires, computers, imaging devices, medicine delivery, you name it. Now, when you go to modulate our brain, you can't just stick it in there. There's no room. We're not born with space for technologies. And so we have to be creative. And you can't put it above the skull or below the skull. So I believe that, thankfully, many of us, of those 1 in 5, will embrace this technology advance. And I'm hopeful that many patients and observers today on this webinar will benefit from our drive as a team to push this forward.
Great. What about, there's some questions about upgradable implants. Is that a simple fix? Do you think that can be through the technology itself, or do you think that means implanting new chips, things like that?
Yeah, upgrading is definitely let's say, credentialed approach. I would say that once you get your first skull implant, your skull defect has already been predefined. And so we have your CAT scan information. So theoretically, for the rest of your life, you can get version 1.0, version 2.0, version 3.0 as the technologies get better. What's even cooler and exciting to think about is your age. Let's say you're age 45 and you get diagnosed with seizures and epilepsy, and you need a battery and wire to monitor seizures. Now, God forbid, 10 years later, you develop a brain tumor. Well, now you take out that old skull implant you had that was just for your epilepsy, and you build a personalized medicine device where half of the implant space is dedicated to your epilepsy, but now the other half is dedicated to medicine delivery to help make sure your brain tumor doesn't come back. And then let's take it one step further. And now that age 60, you got through your brain tumor, and by the way, people don't know you have this implant because you still you're back to your preoperative self. Now you've gone through 40 of seizures and 60 of brain tumors, and now you turn 80 and have, God forbid, Alzheimer's disease. Imagine if we take out your old implant and now put a third section in there that has an Alzheimer's medication that can treat your Alzheimer's, the recurrent possibility of your brain tumor, and still work on your epilepsy. So that really is the wide spectrum of where we can go together.
A couple of questions about any possible ethical problems and/or can you talk about how ethics and the impact of regulation may impact innovation?
Yeah. So I think we are blessed to be in this amazing country, and we are very fortunate to have the FDA overseeing all new innovation. At the same time, that does set up a barrier of entry because it's very costly and labor intensive to develop new technologies such as we presented today. The sweet spot for which we were able to hit was the fact that we were using many of times FDA-approved technologies and FDA-approved cranial implants. And so we were really just the marriage maker of these two FDA technologies with just the creative mindset that they should be bridged together. You may or may not know this, but if you look at a Venn diagram of the entire industry, there's the carpenters and the electricians. The carpenters are the companies, Fortune 300 companies that make skull implants. And then on the other side of the diagram, you have the electricians that make the batteries, wires, or all the cool technologies. 10 years ago, there was really no communication between these two big entities and these organizations. And so that's kind of where we fit in. We were marrying the carpenters with the electricians in a novel way so that our patients could benefit. And so that's the way we were able to streamline the adoption here. But you're exactly right with your question, that if you were to start at ground zero and try to create a cranial implant with your own type of technology, I would agree with you that it's very expensive and time, intense.
Okay, well, as a veterinarian, I have to ask this question. Veterinary patients have exactly the same conditions as humans when you're talking about brain treatments. And I know that you're working experimentally with animals. Have you done any clinical trials in patients with real disease with veterinarians?
Yeah, that's a great question. In fact, we're scheduled to go March live with the world's first MRI-compatible medicine delivery system. And so I've done craniectomies and craniotomies in swine, primates, and many different animals. And I would say that it can carry over to veterinary medicine. There's no reason why it shouldn't. A quick tidbit is that many of us look at the skull as this area that's so scary, but the skull is really simply there to protect our brain. So if we have dogs or cats that suffer from neurological disease, and we can make cranial implants for an animal, which has been done for dogs already using customized implants. If we can make specialized implants that are as hard and stable as a dog's skull or a cat's skull, and they suffer from either seizures or excessive barking, you name it. I don't know the reasons because I'm not in that field. But theoretically, in a 1-hour surgery, you could really open up the scalp, take off the skull, put the implant in, connect it to the brain, and close the scalp. And there's no reason why we should keep this limited to humans.
Is there any potential for neuroplastic surgery benefits to be used in spinal cord injury patients?
Yeah, that's a great question. So I was trained, thankfully, by a wonderful craniofacial surgeon up at Mass General, Dr. Yaremchuk. And since I got to Hopkins in 2011, I've concentrated solely on the skull and the face and the head region. But neuroplastic surgery, the tenets of it include restoration of a neurological patient back to their preoperative self. As you know, neurosurgery has been around for 100 years. Neurosurgeons train for 6 or 7 years, and they really focus their whole mindset around the brain and spinal cord. And that's where neuroplastic surgery really comes into play. It's restoration of these patients back to their appearance, and whether it's at the spine or the head, shouldn't matter. I personally just don't spend time on the spine, but I don't think that's a limit to where this field could go.
Great. Well, thank you so much, Dr. Gordon. That was great presentation, great questions coming in. Thank you everyone for contributing. We're now ready to go to see what Amber has for us. Amber?
Hi everyone. Thank you so much, Chad. That was brilliant. So interesting to have such an incredible insight into, innovation that could affect all of us in such a literal way. So thank you very much. And I loved what you said about bridging the gap in our knowledge. And also I really liked the analogy you had about the car, and you might have an MOT, but you want to make it, appear like it's not had anything done on the outside. That's the idea. And yeah, obviously it's relevant, everything that Elon Musk is doing at the moment, and that's excellent. It's brilliant that technology is moving forward in the way that it should be in this industry. So thank you so much.